will continue to place challenges in our healthcare organizations.
And what indicators might there be on survey that communication needs are not adequately being addressed?
One indicator may be if the organization does not have a plan or a formal plan to address language needs or communication needs. Another indicator would be that the staff who would need to actually implement the plan are not aware of the plan, or if they don't know how to actually use the services that are indicated in the plan. And I think that's why it's very likely to anticipate that surveyors may ask staff to actually show them, how do you work with an interpreter? Please show me how you would contact and utilize your staff interpreter or your bilingual staff or the telephone. Another example would be related to the translation of certain documents. So if the organization is serving a large non-English speaking population and there were no documents, vital documents translated, that could be an indicator that effective communication is not occurring. Surveyors may also look at the patient record to see whether or not during certain encounters, such as patient education or the provision of discharge instructions, whether or not there was an interpreter used to communicate with the patient and the patient's family. So those are some of the things that would probably be likely indicators that an organization is not sufficiently meeting the communication needs of its population.
You mentioned written documents. When are organizations required to translate written documents?
Healthcare organizations making the decision about which written materials to translate into other languages, it starts with determining which of the universe of available materials is vital and which material could be classified as non-vital for limited English proficient populations to meaningfully access the services offered. HHS guidance on this issue strongly encourages providers to, in fact, create a plan for consistently determining over time and across various activities what materials are vital. Now, examples of vital written materials could include consent and complaint forms, intake forms with the potential for important consequences, written notices of eligibility criteria, rights, denial, loss, or decreases in benefits or services. Other examples include notices advising limited English proficient persons of free language assistance, or applications to participate in provider programs or activities to receive benefits. Now, in contrast, non-vital written materials include such things as hospital menus, large documents such as enrollment handbooks, and although vital information can be contained in large documents, the whole document doesn't need to be translated. Classifying materials as either vital or non-vital is sometimes not clear-cut, especially in cases of outreach materials like brochures or other information on rights and services. So awareness of rights or services is an important part of meaningful access and should be factored into materials that are translated, even though they may not be considered as vital to the particular service offered. So the other thing to remember is once you classify your written materials as either vital or non-vital, then you need to look at, again, that four-factor analysis. So you identify documents as either vital or non-vital, and then you determine the importance of the program, the information or encounter, the consequence to the limited English proficient person if the information in question is not provided accurately or in a timely manner. So by applying that four-factor analysis, in addition to classifying your materials as vital or non-vital, we think that you will be able to create an effective plan that really analyzes the services and information available and decide which should be translated into other languages. Some healthcare providers may serve limited English proficient persons who speak over 100 different languages. Now, we recognize that to translate all vital written materials into those languages would be unrealistic. So in the HHS guidance, we include a safe harbor provision for providers. And that safe harbor really allows healthcare providers to do a calculation of the numbers of persons in a language group that they're serving, and to do a calculation, and that if they provide translations for that percentage of the population, then if we were to review their compliance with the law, those actions would be considered strong evidence of compliance with the provider's written translation obligations.
Now, what happens when the Office for Civil Rights receives a complaint against a healthcare organization for failure to provide an interpreter?
That complaint would go to the regional office that handles the state in which that healthcare facility is located. HHS has 10 regional offices in major cities located throughout the country. So the region responsible for the healthcare facility would issue data requests for medical and administrative records, policy, data such as language access plan information, and we would start interviewing. We would interview employees, patients, family, friends. Sometimes we would perform an on-site where we would schedule time to meet with the staff of the healthcare organizations and patients to assess and gather evidence. Now, if we identify a compliance concern based on that investigation, then we would issue a findings letter and work with the healthcare organization to resolve the matter through a resolution agreement and other voluntary measures to come into compliance with the law. That is typically the most frequent way that we obtain compliance with our laws, through voluntary compliance by healthcare organizations once they understand what the laws require. But in the rare situations where we are unable to reach a voluntary resolution, our office has the authority to terminate federal financial assistance. Or we may refer a case to the Justice Department for enforcement, and the Department of Justice also has authority to negotiate settlement agreements in disability discrimination cases that could include damages assessed against the provider in question.
Okay, one final question. How can we use what we've learned today? Amy, do you want to start?
This really is something that's quite important for quality and safety, and I think we need to keep in mind that while we focused in this video on talking about individuals who have communication barriers such as language, or perhaps individuals who are deaf or hard of hearing, that this is something that is important for all patients. And we want to address this in a manner so that we can raise awareness of communication, so that we are helping the quality of care and improving the quality of care for all patients.
Tamara?
Knowledge is the key. Healthcare providers need to understand what the federal laws require in terms of providing language assistance for patients and their companions in healthcare settings. Without effective communication between patient and provider, not only might there be a violation of federal law, but also quality of care suffers.
Great. Thank you both for being here.
You're welcome.
Our pleasure.
And thank you all for joining us today. We hope that you've learned more about federal civil rights laws and Joint Commission standards that support effective communication and language access. From the hospital's Language and Culture website, you can download a list of practical resources that you can use to better meet communication needs.